Our second speaker is Dr. Atish Choudhury from Brigham and Women's Dana-Farber Cancer Institute. He completed his medical training at Columbia University and his postgraduate medical education at Brigham and Women's and Dana-Farber Cancer Institute. He is currently an instructor in medicine and is very active in laboratory investigations of mediators in prostate cancer progression and development of therapy resistance. He'll be giving us a very broad overview of the exciting advancements in the treatment of more advanced prostate cancer. Dr. Choudhury.
Thank you so much, Dr. Kyler, for the introduction, and thank you to Mr. Tatar for the invitation to speak at this wonderful symposium. The talk that I'm going to give is a little bit altered from the slides that you've been given. The slides that you've been given is an excellent talk. However, I condensed it a little bit for the time and tried to focus a little bit more on some of the novel, new things that are coming up. There's new and exciting developments in prostate cancer month by month, and I want to give you an overview of what that's been. So, Dr. Raw, I have no commercial interest to disclose. So, Dr. Ross gave an excellent overview of the epidemiology of prostate cancer, and so I just want to state a couple of points. First, that now around 4 to 5% of patients present with metastatic disease, but if the U.S. Preventative Services Task Force recommendations do go through and there's less PSA screening and it's not replaced by other screening modalities, this number is likely to go up. So advances in treatment of metastatic disease is going to be critical moving forward in managing prostate cancer. And even if that winds up being the case, you know, in a lot of patients that make a huge difference in their mortality, just because not everyone with advanced prostate cancer will die of disease. There's often competing risks that a lot of these elderly men have. And the key point is that the initial treatment of systemic disease is androgen deprivation therapy. Prostate cancer is completely dependent on the presence of androgens for its growth of survival. So castration, either chemical or surgical, produces nearly 100% initial responses, though the depth and duration of that response can be quite variable. So while castration decreases serum testosterone to, quote, castrate levels of less than 50, there is still testosterone around, and that testosterone that is still around can still drive prostate cancer, and I'll get to that when I talk about novel hormonal therapies. So hormone-sensitive prostate cancer, is something that has been treated with hormones for a very long time, and there's a lot of new data that's come up on how to manage this that has altered our view of this population. So first I'll address an old controversy, but something that's still lingering. And this is about whether you should treat with combined androgen blockade, that is with a castration therapy plus an oral androgen, versus castration alone. And this is a review from the Prostate Cancer Trialist Collaborative Group back in 2000. And it's basically looking at, relative death rates with combined androgen blockade versus castration alone. But the key point that needs to be made in the comparison is that the class of anti-androgen very much matters. So it used to be thought that this compound CPA, which is a steroidal anti-androgen, would be effective clinically, but it turns out that the 5-year survival is actually worse with CPA, whereas a non-steroidal anti-androgen, such as flutamide or nilutamide, does give a few percentage points of increased survival. So why hasn't this been adopted for everyone? And it's partially related to the different adverse effect profile. And to be honest, the addition of a non-steroidal anti-androgen does not add much to a toxicity profile, but flutamide in particular causes a great deal of GI side effects that patients don't tolerate. You can see 10% in the combined arm versus only 2% with castration alone. However, Dr. Klotz made an argument back in 2005 that bicalutamide is a superior drug compared to nilutamide and flutamide. It has an improved side effect profile, once daily dosing, and it's a more potent inhibitor. And at this point, he was forced to analyze combined historical data, suggesting reduction in the hazard ratio for prostate cancer mortality by 20%. But since this study, there was actually a randomized trial. Unfortunately, there's been no very large randomized trial, but this trial was updated in Cancer in 2009, suggesting that there actually is a survival benefit of bicalutamide of about 20% at 5 years, which is what Dr. Klotz had extrapolated from previous historical data. So our practice, or at least my practice, is to use combined androgen blockade in the initial treatment of metastatic disease, unless the patient is unable to tolerate the bicalutamide for one reason or another, polypharmacy, LFT abnormalities, or some sort of side effect such as gynecomastia that might improve with withdrawing the bicalutamide. The next controversy that I want to speak about is intermittent versus continuous androgen deprivation therapy. So there's been a thought for a long time that intermittent therapy might be superior to continuous therapy for two reasons. One is quality of life reasons, that there would be decreased toxicity from intermittent therapy. But two, that there is a biological rationale to intermittent therapy, that by decreasing the amount of time that the cancer is exposed to castrate levels of testosterone, it might prolong the period that that patient will not experience resistance to those therapies. So there were some who thought that intermittent therapy would actually be superior to continuous therapy. So I'm going to focus on the two largest studies on this list, the NCIC PR7 and the SWOG 9346. So the NCIC PR7 was intermittent versus continuous therapy in non-metastatic disease. So the key is that these are patients who relapsed, and all of these patients actually relapsed after primary or salvage radiation. So this is actually not a post-prostatectomy patient population, but we're extrapolating. PSA greater than 9 is when they were, was their cutoff to start, and greater than a year after the initial therapy. And they give their intermittent therapy in 8-month cycles to restart once the PSA got to 10. And at a median of 6.9-year follow-up, the overall survival was quite similar between the intermittent and the continuous group. Maybe a tiny bit longer with continuous, but the confidence interval overlaps with 1. And intermittent therapy was associated with improved physical function, fatigue, urinary problems, hot flashes, libido, erectile function. And it was clear from this data that intermittent therapy was non-inferior in these patients. However, last year, Mahu Hussein's group published this study, the SWOG 9346, in patients with actual macrometastatic disease. So in patients with macrometastatic disease, they started a combined androgen blockade for 7 months. In those patients who achieved a PSA of less than 4 after the 7 months, so as you can see, only half the men actually achieved this PSA decrease, they were randomized to continuous versus intermittent ADT. The hazard ratio for death with intermittent treatment was 1.1, and the key thing to note is that the confidence interval here ranges from 0.99 to 1.23. Because the confidence interval overlaps with 1.2, it exceeded the upper boundary for non-inferiority. So they could not rule out a 20% greater risk of death with intermediate versus continuous. But there are too few events to rule out significant inferiority of the intermittent therapy. So intermittent therapy is not non-inferior, whatever you would take that to mean in your practice. There was slightly improved quality of life with intermittent therapy, though. So we have 2 studies, one in the non-metastatic group and one in the metastatic group, that shows sort of similar results, but actually just vary in range. So in our practice, we use intermittent therapy preferably in patients with non-metastatic disease. However, in patients with metastases, it really needs to be individualized. So people who are having severe toxicity from the ADT, even with metastatic disease, it's probably reasonable to give them treatment breaks. But for patients who are tolerating the therapy quite well, it might be reasonable to give it continuously. So talking about the side effects of ADT, what are the types of things that people can have toxicity from? Other than the hormonal side effects and the fatigue, accelerated osteoporosis, hot flashes, sexual dysfunction, weight gain, decreased muscle mass. The glucose intolerance becomes worse lipids, and that increases cardiovascular risk, gynecomastia, anemia, decreased penile size, which has become more of an issue, and cognitive changes. And you can see that this is not a desirable set of side effects that patients would want to undergo for the rest of their life, especially if they're going to live for a long time with metastatic disease. This is a graph that was published back in 2005, approximating bone health fracture risks with ADT. So you can see that the fracture risk increases with the intensity of ADTs. So the more GnRH agonist doses, the faster your fracture risk goes up, and orchiectomy most of all. So what are our recommendations for ADT-related bone loss? We recommend calcium and vitamin D supplementation, though the calcium supplementation has to be done in care because there is some suggestion that too much calcium can worsen cardiovascular disease. For patients with a 10-year risk of hip fracture greater than or equal to 3% based on the FRAX algorithm, some sort of bone strengthening agent is probably warranted. And a baseline DEXA and a follow-up after 1 year of therapy for men on long-term ADT is quite reasonable. There's not anything very specific to do for the other metabolic side effects, however. For weight gain and muscle loss, it's very reasonable to recommend aerobic and resistance exercises, though the magnitude of this benefit in terms of mitigating those metabolic side effects is really unclear in the literature. For patients who have diabetes, you need to monitor their glucose and hemoglobin A1C levels quite closely. For those who do not have diabetes, it's unclear if you would actually increase your screening beyond what you would do normally for somebody's age. And for lipid abnormalities, you would treat according to cardiovascular risk factors per the cardiovascular guidelines. So the third controversy I wanted to talk about is about cardiovascular side effects, because there's been a lot of discussion about ADT and cardiovascular side effects. And in fact, 5 studies have demonstrated increased cardiovascular side effects, and most of those include a lot of the metabolic abnormalities as well as an increased rate of MI. However, a large meta-analysis performed by Dr. Nguyen at our institution, including 4,000 patients from 8 randomized trials, actually showed no increased risk of cardiovascular death over the course of these trials. However, this large meta-analysis is limited to the length of follow-up within those 8 studies. So we don't know if there's an increased risk of cardiovascular death more long-term. However, we can make the conclusion that there clearly is an increased risk for cardiovascular events, but no increased risk of cardiovascular death in short-term follow-up. And so for patients with cardiovascular disease or cardiovascular risk factors, they should have appropriate primary and secondary prophylaxis per their risk factor profile. And I will often refer a patient back to their primary care doctor for recommendations on whether they should be on a statin, whether they should be on a baby aspirin. And if they've already had an MI, they are generally on the appropriate secondary prophylaxis prescribed by their cardiologist. Another key is to avoid ADT in those who don't need it. For example, a patient population where the benefit of ADT might be minimal in relation to their comorbidities. But the flip side of this is that in a patient who might have significant benefit by adding ADT to their regimen, you shouldn't be concerned to add it on just because they had an MI 5 or 10 years ago. If they're on the appropriate secondary prophylaxis, their risk of cardiovascular death by adding on ADT is probably minimal. So the big controversy in prostate cancer that's hormone sensitive that's come out this year is chemotherapy in the management of metastatic hormone sensitive disease. And I'll actually start by presenting the GTUG-15 trial, which was published in Lancet Oncology last year. This was a study done out of Europe with 385 patients that were randomized to ADT plus docetaxel or ADT alone. And the docetaxel is 75 milligrams per meter squared, up to 9 cycles. And you can see, as you might expect, that with addition of docetaxel initially, that you would have a prolonged biochemical progression-free survival, and the hazard ratio was 0.72. However, as you would imagine, the patients who got ADT alone would subsequently get docetaxel on progression. The clinical progression-free survival was also prolonged. And so the overall survival was not really different between the two groups, as you might expect, because most of the patients in this arm might have gotten docetaxel later on in their disease course. There was a slight separation of the curves, but the hazard ratio here was measured at 1.01, even though the median overall survival was 59 months versus 54 months. However, what was presented at ASCO this year was the CHARTED study, the PI which was Dr. Christopher Sweeney at our institution, which also was a randomized comparison of ADT versus ADT plus docetaxel in metastatic patients. And here, the docetaxel was given as a maximum of 6 cycles. And here, you could see that there actually was an overall survival benefit that was not really seen in the previous GTUG trial. Here, the ADT plus docetaxel was 57.6 months versus ADT alone of 44 months. And if you break it out by high volume of disease, and in this study, high volume was defined as visceral metastasis or greater than or equal to 4 bone metastases, at least one of which was extraaxial. And you could see that the separation was much more dramatic in the high volume patients as compared to the low volume patients. The hazard ratio, interesting, is about the same. However, the confidence interval overlaps with 1 for the low volume patients, so this part is a little bit unclear. But if you look at the hazard ratio, all the subgroups benefited, and I won't go through everything in detail, but low volume, high volume, age less than 70, age greater than 70, races, Gleason scores, prior local therapy, all groups benefited to around the same degree. So how do you reconcile these two different curves for overall survival from the GTUG study compared to the CHARTED study? Well, one interesting thing to note is that the GTUG study, as I had mentioned, has 9 planned docetaxel cycles. The CHARTED study had 6. And if you look at the baseline PSA, it was lower in the GTUG study compared to the CHARTED study. So these patients actually had more high volume disease than these patients. The prognostic grouping done by GTUG was with a GLASS prognostic scoring group, but they're reanalyzing this data using the extensive low volume versus high volume that was used in CHARTED to see if their data might fall out in the same way if they separated out the low volume versus high volume in the same way as CHARTED did. The other thing to note is that there were more treatment-related deaths in the GTUG study with the 9 cycles of docetaxel. So, and in both groups, they got subsequent therapy, but the GTUG study completed earlier, so very few of these patients received cabazitaxel as an agent after progression on docetaxel, whereas many of the patients on this arm were able to receive cabazitaxel because it had been approved at this later time point. So in general, our approach to this is that in patients who are young with high volume disease, that there appears to be a certain benefit for adding 6 cycles of docetaxel with initial treatment. However, if a patient is young with low volume disease, it's really unclear how much benefit it's providing, and in patients with a life expectancy of 5 years or less, also unclear. But we would definitely not give chemotherapy in patients who are rather elderly with low volume disease. So treatment landscape in 2014 of hormone-sensitive prostate cancer is different, I would say, than even what I would have shown on this slide last year. So for non-metastatic disease, we would give androgen deprivation therapy, and this androgen deprivation therapy is okay to give intermittently, clearly based on the best data that we have. And when to start, I have not included any slides on that for this particular presentation because this is a morass of differing opinions, but initiation prior to systemic metastases is preferred. For low-volume metastatic disease, I would treat with androgen deprivation therapy versus combined androgen blockade. And for the reasons that I had mentioned before, I would probably prefer combined androgen blockade. And continuous is generally preferred, but this is, again, unless the patient is experiencing a lot of toxicity with their regimen. However, for high-volume metastatic disease, things have certainly changed because in chemotherapy candidates, I would certainly give ADT with 6 cycles of docetaxel, and that would be followed by ADT alone versus combined androgen blockade. And this androgen deprivation therapy or combined androgen blockade, I would prefer to give continuously. And in non-chemotherapy candidates, I would give continuous combined androgen blockade with high volume metastatic disease. And the key issue to bring up is that for all of these patients, because they're going to be on long-term ADT, I would treat with some sort of bone strengthening agent during the course of their therapy if their bone density is low or their hip fracture risk is greater than or equal to 3% based on the FRAX algorithm. So, while the hormone-sensitive section I presented as an overview of controversies, the treatment of castration-resistant prostate cancer, I'm really going to focus on how novel therapies have rapidly advanced the standard of care. So it turns out that even in castration-resistant prostate cancer, persistent pathway signaling through the androgen receptor is maintained through a variety of molecular mechanisms. And these molecular mechanisms include amplification of the androgen receptor gene locus on the X chromosome, increased activity of cofactors of the androgen receptor, increased local androgen production by the tumor itself, activation of the androgen receptor by a variety of growth factors that can signal through receptor tyrosine kinases, proteolysis of the androgen receptor, and splice variants of the androgen receptor that are missing the ligand binding domain and are thus ligand independent, and mutation of the androgen receptor that allows non-androgenic steroids to become agonists. So there are 2 drugs that have been approved over the last few years that are able to inhibit AR signaling even in the presence of castrate levels of androgen. And the first is abiraterone, which is an inhibitor of an enzyme called CYP1720 lyase, which inhibits androgen biosynthesis in the adrenal glands and also in the tumor tissue itself. And the second drug is enzalutamide, previously called MDV-3100, that blocks androgen binding to the androgen receptor, prevents nuclear translocation of the androgen receptor, and inhibits association of the androgen receptor with DNA. So the first trial that showed benefit of these kinds of novel agents is COU-AA301. The phase 3 trial was initiated back in April of 2008, and the first studies were in patients who had previously received docetaxel chemotherapy with up to 2 prior therapies. They were randomized 2-to-1 to receive abiraterone acetate with 5 milligrams of prednisone BID versus placebo versus prednisone BID, and the primary endpoint was overall survival. And you can see that the overall survival curves dramatically shifted with a hazard ratio of 0.65, and the median survival with abiraterone was 14.8 months, and whereas for placebo it was 10.9 months. So this was clearly practice altering at the time that this study came out. There was some toxicity, however, related to abiraterone, and these were primarily fluid retention and edema, hypokalemia, and hypertension. And the mechanism of how that arises is that inhibition of steroid biosynthesis in the adrenal glands causes a buildup of the precursors. And the precursors to to the hormones, to the androgens in the steroid biosynthetic pathway have mineralocorticoid properties. So these three side effects are symptoms of mineralocorticoid excess. And in fact, these adverse effects go down by suppressing adrenal function with the prednisone 5 milligrams BID. So what was more recently presented was abiraterone in the pre-chemotherapy space, but again, this is focusing on asymptomatic or mildly symptomatic patients, and these patients were randomized 1-to-1 to receive abiraterone acetate versus placebo, and the primary endpoints were overall survival and progression-free survival. If you look at the progression-free survival curve, as you would imagine, the progression-free survival is prolonged with abiraterone as compared to prednisone alone, which is not a surprising result because these patients are getting active therapy versus these patients who are not. The question is really, is overall survival increased by introducing an active therapy earlier in the disease course? And unfortunately, the trial was stopped and unblinded early, and when they did an analysis of the overall survival, while the overall survival did benefit the abiraterone arm, it didn't cross the pre-specified boundary for efficacy, so we think that giving abiraterone in the pre-chemotherapy space should improve overall survival as compared to giving a placebo. However, the data actually does not meet the pre-specified boundary to state that in a statistically rigorous way. But an interesting point from the 302 trial is that the safety was actually much better than the 301 trial. If you look at those three symptoms of mineralocorticoid excess that I was discussing earlier, the fluid retention, hypokalemia, and hypertension, it's really very little grade 3 or 4 of any of those three, and it's it's quite similar to placebo. The one adverse effect that was increased in the abiraterone arm compared to placebo was increases in AST and ALT. And so most of these increases occur during the first 3 months of therapy, and then the therapy does need to be held and modified. However, it does appear to be safe, at least, to give this treatment in this particular clinical situation. So next I want to discuss the AFFIRM trial, and again, this is metastatic castration-resistant prostate cancer in patients who've previously received docetaxel. And these were randomized 2-to-1, very similarly to the COU 301 trial for abiraterone, to receive enzalutamide versus placebo. And again, the magnitude of the effect is quite similar for abiraterone. Here, the overall survival in the enzalutamide arm was 18.4 months compared to 13.6 months for placebo, with a hazard ratio for death of 0.631. Enzalutamide is rather well tolerated. There are very few differences between the enzalutamide group and the placebo group in terms of a variety of adverse effects. But one worrisome adverse effect that did come out more in the enzalutamide arm than the placebo arm was seizures. So when they looked back at this data and the patients who received enzalutamide and had seizures, it turns out that those patients had other predisposing factors for seizures, either a pre-existing seizure disorder or cancer involving their skull or their brain. But because of this, this finding, we tend to not recommend enzalutamide in patients who might be predisposed to seizure. So when the PREVAIL trial was performed, which is, again, very similar population and trial design as the COU 302 trial for abiraterone, again, metastatic, CRPC, asymptomatic, or mildly symptomatic, randomized 1-to-1, patients with predispositions to seizure were excluded from this trial. And as you can imagine, that progression-free survival, again, with an active therapy compared to an inactive therapy is dramatically improved. But here, the overall survival also was approved was improved, with a median overall survival in 32.4 months in the enzalutamide group compared to 30.2 in the placebo group. Here, the hazard ratio for death was 0.706 with a 95% confidence interval that does not overlap with 1. So here we're actually fairly confident that enzalutamide introduced to these patients pre-docetaxel does lead to an overall survival benefit as compared to placebo. And quite reassuringly, again, enzalutamide was quite well tolerated as compared to placebo in a variety of adverse effects, and there were no seizures seen in the PREVAIL trial. So if you're excluding patients with predisposition of seizures, you do not expect to see seizures with enzalutamide. So one thing that's been added to the slide deck that I wanted to just bring up is, for conceptual reasons, is a phase 1 trial that was presented by Evstathiou et al. At ASCO this year, the hypothesis being that targeting the androgen receptor and androgen biosynthesis pathways with both abiraterone and enzalutamide together would be safe and efficacious. And the idea is that the resistance mechanisms for abiraterone and for enzalutamide can be slightly different because their molecular mechanisms of action are slightly different. And so the possibility is that by co-treatment that you might delay the onset of resistance while increasing the intensity of the effect. And so we need more efficacious therapy for metastatic CRPC. There's ample evidence that ongoing AR signaling is a mechanism for resistance to both of these therapies, and they're doing a variety of tissue-based correlative evaluations. So what's important to note is that there are no PK interactions. Both drugs are given at full dose without any problem. The only notable toxicity is that there's 73% of patients had grade 1 to 3 fatigue, but the LFT abnormalities and hypertension were not worse than monotherapy. And 20% of patients had primary resistance even to the combined therapy. But one thing to note is that if you look at the median time on therapy in this trial of the combination versus the PREVAIL and the Cougar 302 trials in the pre-chemotherapy population, that this is not better than these. And if you look at the PSA response rates, the combined therapy is actually not that different from the individual therapies on their own. And so this is a more advanced disease population. 13% of these patients have prior chemo, and 8% of these patients have liver metastases. So there's not a lot of data that shows that combining these drugs actually leads to any greater efficacy or delaying time to resistance to these therapies. But it can be given safely, so it's worthy of further study, especially since these direct comparisons are limited by the patient characteristics and the fact that this is a single institution versus the previous multi-institutional studies. So should we do phase 3 trials? So the question is, does more intense AR inhibition result in prolonged response and improved overall survival? We don't know the answer to this question, whether the resistance would develop early with or without the combined therapy. And so the predictive biomarkers are really key. So, the trial that's really going to answer this question is the Alliance trial. It's going to enroll 1,224 patients with metastatic progressive CRPC without prior chemotherapy for METs, who are randomized to enzalutamide alone or enzalutamide plus abiraterone and prednisone. And so hopefully this study will give us an idea of if the combined therapy is superior to, and it's not superior to single therapy, but it's really the question of whether it's superior to sequential therapy. Because you would imagine that patients that would progress on this arm would then receive abiraterone later in their disease course. So understanding how the AR signaling remains active in CRPC has been quite transformative in our understanding of CRPC. Multiple agents with varied mechanisms extend survival and delay progression. However, cross-resistance is really a problem, and other active agents against similar targets, such as orterenal, have failed to meet their endpoint. So going into chemotherapy briefly, docetaxel, as you know, is a standard chemotherapy regimen for metastatic CRPC. And so anytime anyone has a new drug, they're trying to piggyback onto docetaxel to see if it would improve the efficacy of docetaxel alone. And basically, this slide is a graveyard of a variety of compounds that have been tested in this space and don't show any improved outcomes compared to docetaxel alone. This is not to say that none of these compounds are active agents in prostate cancer. It's more that in this particular space, in combination with docetaxel, in a non-selected population, they don't seem to show any biological activity on top of docetaxel alone. However, cabazitaxel, which is a semi-synthetic taxane, has some preclinical data that shows that it's as potent as docetaxel against sensitive cell lines in tumor models, and it has activity against tumor cells in tumor models that are resistant to or not sensitive to currently available taxanes. In the phase 1 trials, the dose-limiting toxicity was neutropenia, and it also had active anti-tumor activity in those phase 1 trials. So the large phase 3 study that led to its approval was called TROPIC. 146 sites, 26 countries, 755 patients that were randomized to receive 25 milligrams per meter squared of cabazitaxel versus mitoxantrone and prednisone, and the primary endpoint was overall survival. And as you can see, there's significantly improved survival with cabazitaxel compared to mitoxantrone and prednisone, of 15.1 months compared to 12.7 months with a hazard ratio of 0.7. However, this summarizes the hazard ratio and the overall survival improvements. And so the dose-limiting toxicity, again, was granulocytopenic fever of 7%. So we consider prophylactic growth factor support in those with higher risk of febrile neutropenia, elderly patients, patients who've received multiple prior chemotherapy regimens, patients who've received radiation with pelvis scatter. So a question is a lower dose of cabazitaxel of 20 milligrams per meter squared as effective oncologically as 25 milligrams per meter squared? Because we know that 20 causes less febrile neutropenia, but that question is under study and we don't know the answer yet. So I personally tend to favor 25 milligrams per meter squared because that's the dose in the published data. But in patients who have febrile neutropenia clearly or have other risk factors, I will dose reduce to 20 even before they start the therapy, thinking that it likely has similar anti-cancer effects. So now let's talk about Sipuleucel-T or Provenge. So the mechanism of action of Sipuleucel-T is that the androgen-presenting cells from a patient are isolated through pheresis, and they're exposed to an antigen, which is a fusion protein of prostate acid phosphatase with GM-CSF. The APC, androgen-presenting cell, takes up the antigen. The antigen is processed and presented on the surface of the APC, and now the APC becomes Sipuleucel-T and is collected, and it's infused back into the patient, which then activates T cells in the body, and the T cells proliferate and attack cancer cells, presumably. So, in the trial, IMPACT trial, the patients were randomized 2-to-1 to receive Sipuleucel-T versus placebo. And then on progression, the patients on the Sipuleucel-T arm were treated at physician discretion, and the patients who received placebo were treated at the physician discretion or a salvage protocol, which is a frozen version of Sipuleucel-T. And you could see that there was an overall survival benefit of Sipuleucel-T compared to placebo, and the median survival benefit was 25.8 months as compared to 21.7 months. And so this 4.1 month survival benefit is very similar in magnitude to 4-month survival benefit with abiraterone, 4-month survival benefit with enzalutamide, 4-month survival benefit of cabazitaxel. So this formulation is similar in terms of the degree to which it can prolong survival. However, it's been very slowly adopted for a variety of reasons. The initial commercialization plan was overhyped, and the administration is cumbersome, and if any of you have tried to give it in your practice, the ability to give it is very limited by a lot of logistics and working with Dendreon. And the mechanism of action is actually quite controversial. We don't actually have a ton of proof that it works in the way that we thought. PSA doesn't go down. There's no measurable prolongation in time to progression. And other agents with a more straightforward mechanism of action have been approved in this space. And because of the cost and the initial uncertainty of reimbursement, the adoption of this therapy has been quite limited. But this level of survival benefit that has been reproduced across multiple trials is a little bit hard to ignore despite all those other caveats. So in my own practice, in the patients that fit the criteria, metastatic CRPC that is asymptomatic or minimally symptomatic, and I think that they can they're safe from a disease and PSA progression perspective for a few months or so, I will recommend Sipuleucel-T as part of their therapy. But there's no way to tell that patient either before the therapy that it will work or after the therapy that it did work. You can tell because they're still around, and they may or may not have been if they hadn't gotten it, but that's really hard to say. So I'll talk about radium-223 next. So, and radium-223 is currently being marketed as Xofigo. So radium-223, radium is in the same column in the periodic table as calcium. And so it naturally targets new bone growth in and around bone metastases. And the agent, when administered by the IV, is excreted by the small intestine. So the mechanism of action is that it goes to the bone at sites of new bone formation, and it releases alpha particles into the tumor. And these alpha particles are quite high energy, but have very low radius of penetration. So the idea is that it preferentially kills the tumor much more than the bone marrow as compared to previous types of radiopharmaceuticals such as samarium and strontium. And so the trial that led to its approval was called ALSYMCA. Patients with confirmed symptomatic CRPC were stratified by whether they received prior docetaxel, their alkaline phosphatase, and whether they received bisphosphonates, and they're randomized 2-to-1 to receive radium-223 versus placebo. And you can see that there's an overall survival benefit. Again, a hazard ratio of around 0.7 with median overall survival of 14.9 months in this arm and 11.3 months in this arm. And if you look at the toxicities, they're primarily hematologic toxicities. There is a little bit of an increase in anemia, neutropenia, and thrombocytopenia compared to placebo, with the only one that's, with all of them being a little bit higher grade 3 or 4. But very little in the way of non-hematological toxicity, except for some GI side effects that are related to the fact that the radium-223 is excreted in the intestine. And if you look across the subgroups, the one that I'll focus on is the prior use of docetaxel, and you can see that alpha-radin, or radium-223, is beneficial both in patients who previously received docetaxel and those who have not. And again, these are survival curves showing that same thing with a hazard ratio very similar in both groups. And the updated analysis also looked at skeletal-related events, and skeletal-related events include fractures, radiation to bone, surgery to bone. And you could see that the radium-223 also prolongs time to first skeletal-related event. So significantly prolongs median overall survival, significantly prolongs median time to first SRE, and it has a benefit to pre- and post-chemotherapy patients, so it's approved in our metastatic CRPC population with bone metastases. However, the thing that is very important to note is that the presence of visceral metastases excludes you from being able to receive this drug. So in my practice, I've often moved the administration of this drug earlier in the process, because you can give chemotherapies once somebody has developed liver or lung mets, but you can't give this drug. So it's just one thing to think about in terms of timing. There are rare declines in PSA. It's given over 6 months. Sometimes you feel really obligated that you want to try to get that PSA down. And so the studies of combined therapy with radium-223 and a hormonal therapy together are currently under study. So just to summarize a bit what I've talked about. So these are the variety of agents that have been approved in metastatic prostate cancer. These are the large phase 3 trials that demonstrated their effect. The disease states are listed. The comparators in most of these groups have been placebo. And the median overall survival benefit, again, of the drug compared to the placebo in a lot of these circumstances is in the range of 4 months. So the big questions are, how much further can we get by extinguishing the AR pathway completely? Meaning, we know that the AR pathway is on in a lot of the patients who've progressed on enzalutamide and abiraterone, and how can we target AR in those cancers? What's the optimal sequencing or combination of agents? We're in very early stages of knowing that. Can we actually cure patients by using some of these drugs earlier in the treatment paradigm? So Mary Ellen Taplin in our group has presented exciting response rates of neoadjuvant abiraterone combined with leuprolide before surgery, with actually a few complete responses, around 20%, which was never seen with leuprolide alone. So it's definitely interesting to know if any of these agents might actually increase the cure rate from surgery. And the last thing that I'm going to just talk about briefly as primarily a laboratory investigator is, can we develop predictive biomarkers of efficacy? So, as Dr. Ross mentioned, there's a variety of genetic biomarkers that have been proposed in the clinical management of prostate cancer, and this is an intentionally busy slide. So, as Dr. Ross mentioned, HOXB13 mutations, BRCA2 mutations, and risk SNPs can be used to help stratify you in terms of your risk of developing prostate cancer. He talked about different markers used in screening. And then there are a variety of prognostic markers for recurrence risk, as Dr. Ross also talked about. But what is primarily interesting in regards to this talk are predictive markers in terms of response to therapy. So there are some markers that have been proposed to stratify patients in terms of likelihood of resistant response to AR-targeted therapies and for how long, but not much has been validated. But as we're starting to sample metastatic tissue and circulating tumor cells from patients with metastatic disease, we're starting to be able to do a variety of tests on the metastatic tissue itself to see if we can find any biomarkers that might predict therapy. And so the one that I want to present today, which was a very exciting abstract that was presented at ASCO this year, is looking at RNA from circulating tumor cells, specifically an androgen receptor splice variant, and does it predict response to therapy. So ARV7 is a truncated form of the androgen receptor that lacks the ligand binding domain, which is the target of both enzalutamide and abiraterone. And so this ARV7 is actually constitutively active as a transcription factor, even in the absence of circulating androgens. And so the study that was presented was a prospective study where the circulating tumor cells were interrogated by quantitative RT-PCR for the presence of the splice variant of androgen receptor prior to therapy. So 12 of the 31 patients who were treated with enzalutamide and 6 of the 31 patients who were treated with abiraterone had detectable ARV7. And very interestingly, the PSA response in the patients who had ARV7 detected was 0 in both the enzalutamide group and the abiraterone group. In 2014, it's very hard to know what to do with this piece of information because this is a very small study that hasn't been validated over a large series. And given that enzalutamide and abiraterone are effective therapies, you don't want to withhold a therapy from somebody who it might benefit that you have not proven to any significant degree that it will not benefit. But if you see ARV7, you might push that patient earlier to chemotherapies or clinical trials if your institution is set up to do this type of test. So this is the type of thing that is on the horizon. You know, this is not a clinically approved test by any means, but it just brings excitement to the idea that some of these genomic markers that we've been hearing about actually might have predictive rather than just prognostic implications. And a lot of these things are going to come out as new therapies come into effect in metastatic disease. So right now the treatment landscape in 2014 is that in non-metastatic castration-resistant patient, there's really no standard. Some people have been giving abiraterone in this setting, but without much data to support the benefit. In metastatic chemotherapy-naive patients that are asymptomatic or minimally symptomatic, I use Sipuleucel-T in the patients for whom that would be a good option. Second-line hormones are reasonable. Abiraterone and enzalutamide can both potentially be reasonable in this space. In symptomatic patients, docetaxel, radium-223, enzalutamide, abiraterone are all reasonable. And then post-docetaxel, again, all the agents that I mentioned are reasonable. The issue that I did not get into, just for the element of time, was the addition of a bone-targeting agent to this therapy. Those slides are in the slide deck, but we also recommend once patients have metastatic castration-resistant disease that they receive denosumab every Q4 weeks or zoledronic acid Q4 weeks. But novel therapies and predictive markers for their efficacy are currently under study. And so I just want to acknowledge Drs. Kantoff, Taplin, Sweeney, and Albige from Dana-Farber, who have been instrumental in getting slides together for this talk, and I wanted to acknowledge my funding sources as well. Thank you.
Do we have any questions?
I will share with you, I'm a neuropathologist, and I haven't seen the intracerebral cancer from the prostate, the primary. And I checked the literature. Typically, the prostate cancer never metastasizes to the brain. And you have slight seizure, but I don't think it's related to metastatic prostate cancer. It is true. There can be epidural metastasis from prostate primary.
Yes, so while brain metastases from prostate cancer is very rare, as you state, it's actually not, sorry?
Non-existent.
Well, I mean, I did have a patient with brain metastases from prostate cancer. It was noted at the time that it was incredibly rare, but it's not zero. But it usually is more commonly skull or dural metastases that you would see that would predispose to seizure.
As a primary care doctor, a lot of times patients come back to me and ask for all sorts of different things, surgeries, cancer treatments.
Yep.
Do you think this is worth it? Because they know me. Of course, it's a challenge to try to answer those questions and keep up. But what I was wondering, listening to this today with the castration-resistant patients, where all these chemotherapies have an improved survival of about 3 to 4 months. How many patients really choose to go through that for a benefit of that short a period of time, and what's the quality of life decrease they experience with that?
So, you know, when people see these numbers like 4 months as a median survival, that is actually a very large range. So there are patients who don't respond at all to a lot of these therapies, and then there are patients who can respond to these therapies for potentially even years. And so the option for these patients, once they have metastatic disease, is usually to try one of these therapies or to not be treated. And when you're not treated, it turns out that the adverse effects of worsening prostate cancer is actually much worse than the adverse effects of the treatments. So non-treated prostate cancer, the primary problems are bone pain, fracture risk, and then a lot of systemic side effects, weight loss, asthenias, all of those things. So in patients who really have a lot of comorbidities or have very limited lifespan, you really have to talk in a lot of detail about the potential risks and benefits of treatment versus no treatment. But in a patient who is otherwise feeling well, doing well, pretty much always treatment is a better option than no treatment.
How about treatment of blacks versus whites?
So right now, there's not much in the way of clinical trial data for metastatic disease suggesting that that the different populations respond differently to the therapies. I don't know if you know, Dr. Ross.
Yeah, the main difference that I've seen is not, like you said, it's not therapeutic response, although there are some difference with how the localized disease seems to be driven. The main difference is that much earlier in the disease course, African Americans tend to be undersampled. It seems like part of that is that they develop anterior prostate tumors that aren't traditionally sampled in our typical biopsies. So they have more aggressive disease up front. And so in terms of just selecting them for surveillance or not, I didn't really talk about this, but we're a little bit more stringent on making sure they do the proper staging before they go into surveillance. My experience is like yours in talking to our medical oncology fellows. Once the disease is metastatic, all of that is in the basket of aggressive disease, and I've never seen anything with response rates being different. And Dr. Luo, they're just starting to look at if A7 is different in that population, but I doubt it's going to be different either. But it's a great question because early on there is a difference.
And I've been burned a couple of times with African American patients with seemingly early disease who've had much worse disease on prostatectomy than you might have anticipated. So I'm also very, very cautious about active surveillance in that population, especially in very young patients. The other thing that I'll just note is that the risk factors for developing prostate cancer, these single nucleotide polymorphisms that are different in different populations are almost certainly different in African and American populations compared to Caucasian populations. So if any of these kinds of studies get clinical use, then clearly there's going to be an ethnic difference. Anything else?
I want to thank you for going through a wealth of information because, as your slides have shown, there's no standard of care or a very limited standard of care once a person becomes castrate resistant. You had that one slide that basically showed the same multiple drugs, but in slightly different orders. The Cipulocel T just not in certain points, and the radium-223 not at certain points. Basically, there is a wide range of different pathways that a patient can undergo, and I think it's it's the same story a different way from what Dr. Ross was saying. There's lots of different ways to treat prostate cancer, and there's lots of both locally as well as advanced. And getting to your point, well, is it worth it? We also have lots of different options for what type of toxicities based on what medications they get, because as Dr. Choudhury said, the alternative of progressive metastatic disease is not fun, and none of our patients are thinking about how bad metastatic disease is when they're looking at length of life. So I want to thank you very much.